What's up, you guys? My name is Lauren. I am a family nurse practitioner, and today I'm going to talk to you about hypothyroidism and where to start and what to do in primary care. And this is not coming from an endocrinologist. So we are kind of starting things up in primary care and managing a lot of this unless it becomes, for some reason, too complex for us. Okay, so you might figure this out one of a couple of ways. One, you are seeing a patient for their yearly physical and you are checking a TSH with their yearly physical labs, which I always do, and you see that their TSH levels are elevated for the first time. Or maybe you have a patient coming to you complaining of a couple of different symptoms, which I will talk to you about, and you send them for labs, and on those labs you find that their TSH levels are high. Or maybe it is a pregnant patient and their thyroid levels are being checked in pregnancy, and that's when it's discovered. Okay, so remember, with hypothyroidism, you are going to have an elevated TSH level, so it is the opposite. Hypothyroidism is an underactive thyroid, but because of that, your body is trying to compensate. The pituitary gland and the hypothalamus secrete more of that TSH, or that thyroid stimulating hormone, which is why you have an elevated number of that on blood work. Now, the two most common things when it comes to hypothyroidism in primary care are Hashimoto's, which is an underlying autoimmune disorder that causes you to have an underactive thyroid, or what we call acquired hypothyroidism, meaning you do not have the underlying autoimmune disorder and there might be a secondary cause as to why you have developed hypothyroidism. All right, so your thyroid gland makes these thyroid hormones, and when you have hypothyroidism, they are not making enough of that hormone. And the thyroid hormones control things like metabolism, energy, heart rate, and your body temperature too. So think of it this way: when you don't have enough of that hormone, everything in your body is going to slow down, which is why you are going to have some of the common symptoms of hypothyroidism, which are fatigue, feeling cold, bradycardia, weight gain or difficulty losing weight, constipation. Sometimes patients are depressed. You might have dry skin or hair thinning, and sometimes you can even get irregular periods. So now let's talk about the two different ones: Hashimoto's thyroiditis versus acquired hypothyroidism. So Hashimoto's is that underlying autoimmune disorder. So think of it as your own immune system is attacking that thyroid gland. And because of that, the thyroid is going to get damaged over time and stop working as well as it should be. And that can really happen at any point in life. So when you check a patient's TSH levels and you see that they are high, when you repeat labs, you're going to want to check things like a free T4 and those TPO antibodies. If the TPO antibodies are high, that means that this patient has Hashimoto's. If the TPO antibodies are normal, that means that that patient does not have the underlying autoimmune disorder. So if they have normal TPO antibodies and they have acquired hypothyroidism, that means that something else may have happened to cause their thyroid gland to now not be working as well. And that could be things like thyroid surgery, maybe they had radiation, certain medications can do it, being deficient in iodine can do it, a viral thyroiditis, or sometimes even pregnancy or postpartum. Now, either way, Hashimoto's and hypothyroidism are both treated the same way and are both being treated mostly based off of a TSH level. Sometimes you will find that patients have discovered, whether it's you or with somebody else, that they have Hashimoto's, but their TSH levels are normal, meaning that as of right now, although they have that underlying autoimmune disorder, their thyroid is still functioning properly, and you don't necessarily have to put them on medication. You can wait until you see that TSH level go up, meaning then at that point, the thyroid is not working properly. Unfortunately, we don't check TPO antibodies very often in primary care. We usually only check them once we discover that the TSH is elevated, mostly because insurance doesn't cover it unless we have a reason to. But that's okay because you're doing this based off of a TSH level, so it's not really changing much. Okay, so how do you treat these? You are going to put these patients on a synthetic thyroid hormone, aka levothyroxine. A normal TSH level is 0.5 to 5. Some people won't treat hypothyroidism until a TSH is significantly high. We're talking 10 or plus. Some people will get treated or put on medication if their TSH is very mildly elevated, like let's say 5.5 or 6, because they are super symptomatic. But when you ask a patient if they have the symptoms of hypothyroidism, it could be really hard because sometimes a lot of people have those symptoms and still don't have hypothyroidism. So that is a decision between you and your patient. But if your TSH levels are 10 or above, you should be putting these patients on levothyroxine. And the treatment or the medication, like I said, is the same for both Hashimoto's and acquired hypothyroidism. So where do you start with these? You're going to want to start at a low dose. If they're an older patient, you're going to want to start even lower, like 25 micrograms. If they are a younger patient or less than 65 years old, maybe you could start at like 50 micrograms. And you can increase by 25 micrograms every 4-ish weeks or so after you repeat their labs and see if their TSH levels have come down or are now within normal limits. And you will see that sometimes you're going to have to go up on meds and sometimes you're going to have to go down on meds. And sometimes you're going to have to do the most bizarre regimen, like 112 micrograms 5 times a week and then 125 micrograms Saturday and Sunday. Because you just need to perfectly get a patient at their correct dose. So it takes a lot of tweaking sometimes, which could be very frustrating for patients because they have to go for repeat labs every 4 weeks. Now, you don't necessarily have to get a thyroid ultrasound for these patients, but if they have Hashimoto's thyroiditis, you can. But the ultrasound is most likely going to show you that they have an irregular thyroid gland or a multinodular thyroid gland, meaning there are a bunch of little nodules or cysts. Another weird fact, patients with thyroid cancer, you won't necessarily see abnormal labs for those patients. You might only just feel a lump or a mass on their thyroid gland when you are assessing them, but their TSH could be completely normal. Other important things when it comes to hypothyroidism and treating it, you want to make sure that your patients are taking the medication the correct way. So many times I see patients and their TSH levels have gone up even though they are on their medication, and that's because they just began taking it the wrong way or were taking it the right way just because they were, but they were never actually taught. So you want to make sure that a patient takes these medications first thing in the morning with just water on an empty stomach, and then 30 to 60 minutes later they can eat or take their other medications. They don't even want to take these meds with vitamins, okay? Completely empty stomach all by themselves. I have also seen that patients with significant GERD have trouble with these medications because if they have too much acid in their esophagus, that can affect the levothyroxine's absorption. And so that's another thing to consider if all of a sudden their labs are abnormal, but they've been taking the medication the right way for quite some time now. And then I'm not going to get into this too much because it is not something that we do all of the time in primary care, but it is something that I have done if a patient has difficulty getting in with an endocrinologist. So levothyroxine is an LT4 medication. Now, if your patient is on levothyroxine and they are still very symptomatic from their Hashimoto's, you can make the decision to put that patient on an LT3 medication in combination with levothyroxine to help better manage their symptoms. A common LT3 medication is liothyronine, and what you would do is titrate down on their levothyroxine by about 25 micrograms and add in a low dose of that liothyronine. Anywhere from 2.5 to 7.5 milligrams a day, and the patient would be on those 2 combo meds. Now, some patients need brand name meds versus generic meds because one works better for the other. However, if you are starting to run into problems with controlling patients' TSH levels despite trialing different titrations of their meds, now is a good time to send out to endocrinology.